Hello everyone, let's see WARTHIN'S tumor from oral pathology. So WARTHIN'S tumor is a benign salivary gland tumor and it is the second most common salivary gland tumor. It is almost exclusively seen in parotid gland. Why its name is WARTHIN'S tumor? Because it was described by WARTHIN in the year 1929. The other names are adenolymphoma, but it is not very preferred. The preferred name is papillary cystadenoma lymphomatosum. Why it is named this, we will understand it better by the histology. But let's see, it is an adenoma which exhibits cyst formation. And there are papillary projections into the cystic spaces, and there is a lymphoid matrix showing germinal centers. That's why this name is given to WARTHIN'S tumor. Let's see its histiogenesis. There are numerous theories, but everything is uncertain. But the currently accepted theory is that the tumor arises from salivary gland tissue. This salivary gland tissue, which is entrapped within the paraparotid or intraparotid lymph nodes during embryogenesis. According to Allegra, it is a delayed hypersensitivity disease. That is, it is an immune reaction to the salivary ducts and the cells undergo oncocytic changes. Oncocytic changes, the two main changes here would be, one, there will be high number of mitochondria, and second, there will be granular cytoplasm. There is a strong association of this tumor with smoking. There is a strong association with smoking, although almost 98% patients are smoker. It is associated with Epstein-Barr virus, but it is not very clear. It is considered to be a disease of men. This has a male predilection and it was almost exclusively seen in males. This is a difference. In other salivary gland tumors, all others are have a female predilection. This has a male predilection. Age, it is seen usually in 6th to 7th decade and average is 62 years. This tumor is superficial, that is, it will be either lying just below the parotid capsule or protruding through the parotid capsule. It is rarely large, so it is usually 3 to 4 cm, not more than that. It is not very painful, it is firm to palpate, and clinically we cannot distinguish it from other benign tumors, benign salivary gland tumors. Now let's see the macroscopic features. It is smooth, soft parotid mass. It is well encapsulated. This point has to be remembered. It is well encapsulated. There are variable number of cysts which contain clear fluid, and there are areas of hemorrhage which can be seen. Now let's see the histopathology. The histological component of WARTHIN'S tumor consists of, one is the epithelial component, second is the lymphoid component. The lymphoid component is darkly stained and it can either be scattered or in the form of germinal centers. We will see it in the diagram. Now let's see the epithelial component. This is a two-layer, that is bilayered oncocytic epithelium. Oncocytic, so there will be high number of mitochondria as we saw earlier. This epithelial component, we saw it is bilayered, so there will be two layers. First is the inner layer and second is the outer layer. The inner layer is the layer which is towards the lumen. That is, the luminal layer is the inner layer. It is tall columnar and it has finely granular eosinophilic cytoplasm and hyperchromatic nuclei. There is hyperchromatic nuclei. An outer layer is cuboidal, oncocytic, triangular and fusiform. In the cystic spaces, there is the eosinophilic coagulum. There can be seen as focal areas of squamous metaplasia and mucus cells. Prosoplasia may be seen. Fluidocoagulum, its gross appearance is chocolate colored fluid. Now let's see the diagram. This is a normal salivary gland. This is a normal salivary gland. We saw that this WARTHIN'S tumor is well encapsulated. So this is a capsule. This is the capsule. It is well encapsulated. We saw that the lymphoid component can either be in the form of germinal centers. This is made light in the center because the center is active, so it takes up lighter stain. This is the nodular area of lymphoid with germinal center. And we saw that the lymphoid can either be scattered. So we have made both. This is the germinal center and this is in the scattered appearance. Then we saw the epithelial component. Epithelial component, there is a bilayered oncocytic layer. This is a bilayered. So we can see two layers. One is the inner layer. This is the outer layer. We saw that the inner layer is towards the lumen. This is the lumen of the cell. and towards the lumen will be the inner layer of cell. So this is inner layer of cell, this is inner layer of cell. We saw these are tall columnar, and it has a hyperchromatic nucleus. And then the dots we have made in this are the oncocytic changes which we are trying to show. And the outer layer is the cuboidal layer. So this is the bilayered oncocytic epithelium. So as we can see, we have seen well encapsulated tumor. There is the lymphoid with germinal center, scattered appearance of lymphoid pattern, inner layer of cell, outer layer of cell, lumen, and in the lumen we will see a eosinophilic coagulum. Now let's move towards the treatment. Surgical excision without damage to facial nerve lesion. It is usually a superficial or small lesion. It is well encapsulated, so it rarely recurs after removal. Malignant transformation is extremely rare. Hope you found this video helpful. Do like and subscribe. Thank you.